Well, thanks for joining our discussion of the social determinants of health, the U.S. Census, and COVID-19. That certainly gives us enough to talk about for the next 45 minutes, I think. Hi, I'm George Dealey. I'm the Vice President of Healthcare Solutions at Analytics Software Company, and HIM's sponsor, Dimensional Insight.
And I'm Julie Lamoureux, a Project Manager in Dimensional Insights Consulting Organization. George leads the team at Dimensional Insight that designs and develops healthcare-specific analytical applications.
And Julie is a dentist by training and also our resident statistician. And that's in addition to her role in making sure that our healthcare customers are successful with our technology and applications. So we're going to look at a few social determinants of health from a few different perspectives. First, what we mean when we talk about social determinants, how we can use data from readily accessible sources to quantify and analyze them, and how we can use that data in turn to merge it with information on health outcomes, and specifically how the data generated by the COVID-19 pandemic can be used to highlight and even quantify the disparities and inequities around the impact of the coronavirus. Then finally, we'll look forward to how this type of information and what we've learned from it can be used in the future. So Julie, let's start with what the social determinants of health are.
Well, social determinants refer to the physical environment and social circumstances that impact a person's well-being. Examples of these include housing, food and nutrition, income, employment, and access to transportation. It has become increasingly clear that these factors have an even greater impact on an individual's health than what is represented by the information that routinely is collected in healthcare settings like a physician's office or a hospital. A statistic that is often cited is that social determinants account for about 80% of the variability that explains an individual's health, compared to 20% for factors that are traditionally captured in medical records.
In fact, healthcare providers are increasingly screening for social factors, and formal code sets such as the ICD-10 CM clinical modification diagnosis codes are beginning to add designations for social determinants, but it's really early days here. The current reality is that there's just not enough information on enough individuals to provide much help in measuring and improving the health of populations. But given the importance in the potential of social determinants, we think it's at least worth trying to integrate them into our various approaches to population health. So that leads to the question, how can we quantify social determinants to make them interpretable and actionable? Julie, any ideas?
Of course, there's a variety of publicly available data sources that are quite useful. Initiatives from federal, state, and local government agencies, as well as nonprofit organizations, all contribute important information. However, the information tends to be quite highly summarized at the level of geographic region. In other words, it's not attributed to specific individuals, but it can still be useful. For example, there are several approaches for transforming this data into a single number, an index, or a composite score, which gives a starting point for quantifying social determinant with regional data that is available to us. George, can you enlighten us as to what those are?
Yes, I can. But before I do, I wanted to mention in our presentation materials, you'll notice that I'm clicking on images here. That actually will take you to websites that will provide the information, background information on what we're discussing today. So I was actually scrolling through the CDC website there. So yes, that's where something called a social determinants index comes in. There are several countries around the the world that have created social determinants indices to help manage the health of their population. And the UK and New Zealand are two good examples, both of which have very advanced approaches to population health and lots of data at the individual level. New Zealand arguably has the best population health systems in the world. And they use their index to determine the allocation of various types of resources and to explore variations in health outcomes. The US doesn't have comprehensive person level information on populations, at least yet, but there still are some options, and we've identified two of them. So first, there's the social vulnerability index that's defined and provided by the CDC, the Centers for Disease Control, and also the social deprivation index, which was devised by a Washington-based think tank, the Robert Graham Center. Now, they're both very similar in that they use publicly available data on social determinants and health outcomes to assign an index to geographic regions that reflect the levels of vulnerability or deprivation as indicated by a specific set of social and physical factors. Now, the Graham Center's index has some good research behind it that gives you some insight into how it works. So this is the Graham Center's website. Again, I clicked on the image, and there's a few things of note here. One is the social determinants factors that are used in the social deprivation index model, and you can see them here. These are taken from American Community Survey data. We'll be talking a lot about that. And you can also download the data that has the social determinants index score itself, as well as the respective factors that go into computing it. And as you can see here, this data is available at various levels of census geographies, including county, census tract, primary care service area, and the Census Bureau's version of zip code, which is the zip code tabulation area. And we'll be talking about those geographies. And they also provide some good background information on references and references in terms of how they applied some of the thinking behind social determinants into this research.
So what does this do for us? We can use it to visualize regional patterns of disparities across the US. Here's an example that shows, first, the social deprivation index summarized at the state level. So you can see that the coloring indicates higher or lower social deprivation index. But that kind of summary blends a lot of information together, and it's not particularly meaningful in healthcare. So if we take it down to the county level, we get a more nuanced picture of the variation from county to county. The shading represents social deprivation index quintiles. So all 3,000 US counties, or 3,000 plus US counties, are ranked by social deprivation index, and then divided into 5 ranked groups, the quintiles. The red shading represents the highest social deprivation, and the green, the lowest. Then if you bring it all the way down to the zip code level, we can begin to see what's going on within individual neighborhoods. George, you want to?
Yeah, so using the example of Massachusetts, so if we get all the way down to the zip code level, we can see some very interesting and actually familiar patterns. So we're looking here at the greater Boston metropolitan area. And if we really zoom in, we can see the difference in the social deprivation index is represented by these quintiles, with red being the highest level. We can see this at the neighborhood level. So if you're at all familiar with Boston, you would see that there are certain areas here where we would probably expect higher levels of social deprivation, and other areas where we would expect lower levels. And that's reflected in the shading here. So this provides us a much more granular form of information than we'd have if we were just at the county level.
Well, that seems pretty powerful. So where does this information on social determinants come from?
Well, there are a few possibilities. Those are the USDA, the U.S. Department of Agriculture's food insecurity data, which shows food deserts across the U.S. There's the Centers for Disease Control. We looked at a few examples of that earlier. There's the Community Commons, which is an interesting nonprofit collaborative around social determinants data, very useful. Then there's the Census Bureau, and in particular, the American Community Survey. And of all of these, there's really one incredible resource that really stands out, and that's the Census Bureau. And that's what we're going to focus on primarily today. So you're likely familiar with the Census Bureau's constitutional mandate to literally count or enumerate every person in the US every 10 years. That's known as the decennial census. And as it's been very much in the news lately, we know that there's some controversy around it. But that's not the only thing that the Census Bureau does. Over the years, its role has evolved to estimate versus enumerate various aspects of the population, economy, and society. So the estimates, in addition to what the Census Bureau comes up with for population, are around business and manufacturing activity, housing, and then the American Community Survey, which combines population data with social factors. And that's what's used by both the CDC's Social Vulnerability Index and the Graham Center's Social Deprivation Index. So the American Community Survey is a very useful resource. And there are a few very significant advantages of using the data. We'll refer to it as the ACS for shorthand. So first, obviously, it's very rich in social determinants information. Otherwise, we wouldn't be talking about it. It's highly curated and uses well-proven statistical techniques for its estimates. So it's very reliable. It's built on top of a foundation of the data that the Census Bureau collects for population measures. And it's fairly timely as far as this type of data goes. About 20% of census geographies get updated every year, with the entire US being updated every 5 years. So it's kind of a rolling 5-year snapshot of the social determinants of the entire country. And then finally, it's very geographically granular, which is really important because we don't have information at the level of specific individuals by and large, like the UK and New Zealand. So it's really important to have very granular geographies that have the reflect the social determinants information. So Julie, can you tell us a bit about these census geographies?
Sure. There's quite a few of them. So at the highest level, we would have an entire state. But at the most granular level, there's the census block. Then there's many other in between. There's counties, congressional districts, town and cities, and zip codes, and the list goes on. But the census blocks are literally the building blocks that are used to assemble all of these geographies together. They represent population of about 600 to 3,000 people, neighborhoods in many cases. And all the social determinant data is available all the way down to the census block level, which is regarded highly by professionals in the social research arena. So we can be pretty specific with our analyses. Once you have the residence information on patient, you can locate the social deprivation index for their neighborhood. which is a highly valued information without the distortion of having to ask patient what all the factors that contribute to the social deprivation index is.
So among the many benefits of using the American Community Survey data are that it's free and it's easily accessible. You know, the Census Bureau has a variety of different tools that help you use the data, and we'll mention just a few of them. So here's an example of the type of information that's available within the 5-year profile. So we'll use an example here from New England, Census New England HIMSS. Let's say that we want some information on Maine, and we've selected a place that's a specific census geography designation. And here are the places within Maine. So if we wanted to, for example, take a look at the information for Bangor, Maine, we've selected that and we collect this link, and we can see the various information associated with Bangor. So let's look at, for example, the housing characteristics. So we click on that link, and what we're going to get back is kind of a snapshot of all the information associated with housing. And you can see it's pretty extensive. And the other categories were also related to social determinants. So taken together, we get a pretty comprehensive profile. Now, this data looks pretty raw, admittedly, but there's a variety of different things that you can do to customize it and prepare it for use with electronic systems. Now, in addition to this, so this was an interactive process. I had to manually select the information we were looking for, but there are also programmatic interfaces, APIs that are available where you can define a specific query string for the geographies and the information you want for those geographies, and the data comes back in a nicely formatted electronic format. So what are some of the other things that you can do? Well, we've talked a little bit about the importance of locating individuals in specific regions, census regions. So one other tool that the Census Bureau makes available, which is very important, geocoder, yes, geocoder, is the geocoder. So the geocoder is a tool that allows us to provide an address. So let's say that you've got information from your electronic health record systems on your patients, which include their address or population health data sets. So the Census Bureau geocoder tool provides the ability to put that information into this system, and we'll use an example here. This is actually our business address. And what it's going to return back is the specific latitude, longitude coordinate. So we've got a very specific geographic position, but it also places that address within specific census blocks. So Julie described the census block as the most granular level of census geography, and then all of the geographies that build on that. So we can see the specific block of this location, and then we go up from there, the census group, the census tract, and all the way up through the entire hierarchy. So very, very powerful tools, again, easily accessible and free. Now, there's a tremendous amount of data and resources that are available here. So one of the things that the Census Bureau has done a really nice job of is providing information on how to use it. So this is the Census Bureau's Knowledge Resources website. And there's all kinds of different tools here. As you can see, there's webinars, courses, resources. You can even request specific training. But one of the things in particular that I found to be very useful is something called data gems. So these are little videos, 2-3 minutes that are available on YouTube that will provide you with enough information to understand what's available for certain topics and then how to go about using it. These are actually very entertaining. If you do this, you'll become very familiar with Alexandra Barker, who does quite a few of them.
But the real power and potential lies in integrating social determinants of health with other data like health outcomes. Here are two examples of how that can be done. The first example is at the macro level. We can combine social determinants and various outcomes data at the county level. The County Health Ranking Project is a collaboration between the Robert Wood Johnson Foundation and the University of Wisconsin and compiles population health data from publicly available sources. It organizes data consistently for all U.S. counties so that it can be conveniently analyzed across the entire U.S., as well as within specific county regions. It includes a set of measures or KPIs divided into health factors, primarily social determinants, and health outcomes. With this data, you're able to see the correspondence between the health factors and the health outcomes. But that's just the data and an analysis side. County Health Rankings also provides guidance into how to put this information to work to improve population health.
So as Julie was describing the County Health Rankings project, I was going through the website and providing an example, another New England example from New Hampshire, so we could see both the kind of a visual perspective on health outcomes and health factors. And then if we clicked on an individual county, like Cheshire County, we can see the specific measures, key performance indicators, and their rankings both within New Hampshire as well as across the US. So very useful information. But again, that is at the macro level. So in addition to that, we wanted to look at an example at the micro level. And what we mean when we say micro level is if we do have information on individuals, how can we incorporate that with social determinants information? So we've got another example. This is a prototype that we've built to kind of make the points here. As Julie mentioned, this is what we were planning to show at HIMSS. So we looked at the social determinants information. Now let's look at an example of how we can incorporate outcomes information. So if we bring this down to the zip code level again, what we're going to look at is diabetes incidence in Massachusetts. And what we've done here is to create a scale model of the Massachusetts population. And this was synthetically generated using an open source tool called Cynthia, which is designed to do exactly that, generate populations using real population data as a basis. So we have kind of individual level data here. And we use that information to highlight diabetes incidence throughout Massachusetts using a similar approach to what we did with the social deprivation index. So we've divided all the zip codes into quintiles, and the darkest ones, the darker red shading indicates the highest level of diabetes incidence. So we can see some familiar patterns here. In fact, if we go over to the metropolitan Boston area, we can see a concentration of high diabetes incidence. Interesting in a lot of the same areas that there was high social deprivation, but we also see a high incidence of diabetes elsewhere in communities that ostensibly have a lower social deprivation. These are some of the wealthier suburbs outside of Boston, but they still have high diabetes. What happens if we combine the two together at the zip code level? So the indication here is that these are areas, the areas that are shaded dark red, they're the ones with a combination of the highest social deprivation and the highest level of diabetes incidence. So because this is at the zip code level, as we really get to a granular level, we can get a very good sense as to where there's opportunities to intervene to potentially head off the development of diabetes, depending on what kind of information that we have. So we'll choose this particular zip code neighborhood. Looking at it, it's probably all the way down to the neighborhood level. So what we're able to see here is the regional information. So this was for this zip code. So we can see its location within Boston, which is also within Suffolk County. We have both the highest diabetes quintile, highest diabetes incidence quintile, as well as the highest social deprivation index. And we can also look at the component scores of the SDI here as well, again, for that zip code. Now, because this was based on individual level data, we also have information on specific people. So we could generate a target list of individuals or patients based on these criteria. So let's say, for example, we wanted to look at just the individuals that had pre-diabetes. We might be able to head off the development of full-blown diabetes and generate that list and use it for proactive population outreach. So an example of the kinds of things that you can do by combining this very specific individual level data with the geographically oriented information on social deprivation and social determinants.
So we began working on this project at the beginning of this year in preparation for the big national hymns in March. And we were all set to go, looking forward to showing off this and many other things. And then within 2 days' notice, it all went away. Then came COVID-19 in a much bigger way than we ever expected. But for all the adverse impact and tragedy of what became a worldwide pandemic, it has generated a wealth of very comprehensive data that has been invaluable in managing the response to COVID-19. In terms of good data practice, it checked all the boxes. The data has been available on relatively timely basis, updates from around the world every day. It was reasonably well defined and curated. For example, the meaning of the primary measures in Europe and Asia were the same as the ones that we were using here in America. It was easily accessible. It can easily be downloaded from several convenient sources. And it opened opportunities for a significant amount of innovation in terms of visualization and communication through data, as well as for data science to find useful patterns in the data.
So we quickly realized that we could do something very similar with the COVID-19 and social determinants data to what we'd done with diabetes outcomes. And at the same time in Massachusetts and elsewhere, it was becoming increasingly clear that the coronavirus did indeed discriminate. Areas with high social vulnerability were getting hit much, much harder. And initially, the observations were anecdotal. We could read about it in the newspaper, but that was quickly backed up by the data, especially as it became available at levels of geographic granularity below the county. The initial information was reported at the county level, but at least in Massachusetts, as we began to see data at the city and town level, it presented a very different picture. Now, we still don't have good zip code information. And again, the most comprehensive data sets are at the county level. So we're kind of limited in what we can do. But given the interest in issues around disparity, inequity, there's a pretty good chance that more geographically specific information will become available, probably in the near future, I would guess. So the principles of combining the COVID and social determinants data are the same as what we just described earlier in our last example around diabetes. Now, at this point, as I just mentioned, it's really just county level, and it's what's most readily available. So for our example, we've extended our county level data set to include information on COVID-19. I'm going to move back into our prototype. This is one example of how COVID information has been represented. This is from the Johns Hopkins website. All right, so let's take a look at COVID data. So what we've done here, and again, we've got county level information, and we can look at this across the entire U.S. in terms of social deprivation. So this is what we already looked at. This is a county level. Then we bring in our county level COVID data, and this was sourced from the New York Times data set, which is updated every day. Johns Hopkins is another example, but New York Times data is particularly accessible. It's included in it's made available through a GitHub site, so it's very easy to download and combine with other data. So we can see some patterns here that we're pretty familiar with, especially as we get into the Northeast. Again, we'll use the Northeast as an example because that's the one that we're most familiar with, and has also been was an early example of very high COVID incidence. So no surprises here. Boston area, urban areas just north of Boston, the entire Providence area. They're in a big county, so you can see the lack of geographic specificity. Then we get down into New York, both the city, Long Island, and some of the suburbs outside of New York down into New Jersey. So that pretty much jives with what we've been seeing in the news. Now, if we do the same thing that we did with diabetes, we overlay social deprivation with COVID diabetes incidence. And just to be clear in terms of what we're using, the measure that we're focusing on here is the cumulative number of confirmed COVID cases up through September 30th. So a few weeks back per 100,000 of population. So we're using a KPI that has a population leveler here so that we can look across these areas and use a common measuring stick, if you will. So now what happens when we combine the two data sets? So again, we're using quintiles and we're adding the quintiles together, which is going to have the effect of highlighting hotspots. And a few of these go away. Long Island goes away, as you would expect, not as high a level of social deprivation there, but there are a few areas where it's pretty clear. So Suffolk County, which is where Boston is, Providence, Rhode Island, some of the areas over here in the central part of Massachusetts where Springfield and Holyoke are included. So it's pretty clear looking at this visually, and this is one of the advantages of visualizing data, kind of jumps right off the map here in terms of where we have both high levels of COVID incidence as well as high social deprivations. Now, again, this is the county level, not as helpful as if it were all the way down to the zip level, or better yet, the census tract or census block level, and that's what we're really trying to get to. So as that information becomes available, we would be able to do that that same type of very granular analysis. And ultimately, as the information becomes available at the individual level, we would be able to generate individual lists like diabetes. So that speaks to some of the potential for using this information for true population health.
So George mentioned something important. We don't all need the same level of granularity in social determinants of health. When organizations want to get involved in health community programs, they want to identify areas of greater needs. It's usually preferred to go all at the finer granularity so that they can pinpoint areas of greater needs like census block or census tract. In other situations, like when you create a certificate of needs in an area, the zip code level is usually enough. And in the case of social policies, it's usually preferred to use the county or the state level information. And that's why that data is available most of the time at the county level.
So where do things go from here? As we've mentioned, despite the fact that the worldwide pandemic has truly been a tragedy, it's also had the the effect of advancing analysis and data science. It's provided us with highly available data available on a timely basis. By and large, it's trusted and reliable. I think time will tell as to how accurate the reporting has been, but I think we can assume that it's been pretty good because it's certainly been reflecting what's actually been happening. But in addition to that, there have been some real advances in the area of data science as a result of the opportunity to use this type of data. So one example of that is the CDC, the Centers for Disease Control forecasts that are sent out every day. Now, obviously, the CDC has been in the news a lot and very controversial. So there's a question around where do these estimates come from, these daily estimates around deaths and cases. And it's not necessarily directly from the CDC, it's from an ensemble, what's called an ensemble forecast from 32 different modeling groups. And this will give you a sense of who's involved. It's literally a who's who of organizations, public, private, government, and others that are at the forefront of healthcare research, data science, and machine learning. Now, this is government funded, so the data is shared. The analytical methods that are used by these different groups are completely transparent. In a lot of cases, you click on this link, it'll take you directly to a GitHub account. You can look at the algorithms and the various methods that these groups are using. And that provides the benefit of transparency, where these groups can look at what one another is doing, provide constructive criticism, borrow ideas from one another, and refine their models so that they all collectively get better and better over time. And interestingly, this is something that was predicted by John Tukey, who arguably is the father of modern data analysis, who in a paper called The Future of Data Analysis way back in 1962 predicted that something very similar to what today's data science would emerge. In fact, the term wouldn't be coined for a couple of decades, but it was the idea that data could be used as a science in and of itself if it were widely enough available, if analytic methods were transparent, so people could researchers could compare results with one another, and it could evolve in a way that other sciences have evolved using the scientific method. So COVID-19 has actually been a great example of that really being realized.
And we're just scratching the surface in terms of the role that the social determinants of health can play in research and analysis. And the learning and conclusions from that work is being communicated widely through innovative visualization from a variety of sources because the data is available.
So to that end, we wanted to show a few different examples of visualizations because in addition to the innovations in data science, there have been a lot of great examples in terms of how this information can be visualized. And we have a little bit of time to talk about these. So we've chosen 3 organizations that we feel have done a particularly admirable job of helping to visualize this, what would otherwise be very raw information when you look at it in tabular form, and kind of breathe some life into it to help communicate what's going on within the pandemic and inform public policy decisions and help the public understand the reasons for those. So we'll start with Johns Hopkins. You know, you probably hear Johns Hopkins referred to a lot in the news as the source of this information, not just in the US, but from around the world. Here's a great example of kind of a matrix dashboard that shows information for 3 leading measures, new cases, tests per 1,000 people, and % positive ratings. So they're all kind of related to the same idea. And we can bring this down to a specific region, such as New England, and look at how states compare with one another. These graphics do a good job of highlighting things such as the daily variability in the measures. That's not real variability. It's more artificial due to reporting lag, and using a 7-day or 14-day moving average just makes a lot more sense. Another way to view this information is through a map. We showed this a little bit earlier, but this is an interesting approach to a map in that it doesn't really emphasize the true geographic distribution, but it provides kind of a sense for the contiguous nature of these states and where there are outbreaks. So another example is the New York Times, which has put a lot of energy into staying up with the coronavirus and reporting on it. And they have some very interesting ways of representing the data as well. In fact, here's an example of a map. It's a little bit different than the one that we saw from Johns Hopkins, in that this is spatially accurate, so it gives us a different perspective on the clustering all the way down at the county level. So whereas that Johns Hopkins map was interesting and useful, this gives us a different perspective. And they've also broken these visualizations down to various categories, and then visualizing the data to provide some additional context there as well. So that's the New York Times, and again, all of these links are live, so you can go in and explore them a little bit further. And then finally, Our World in Data is a data collaborative that's using information from around the world, and they've got some very interesting charts as well that provide some perspective on where the U.S. and other information are trending over time. So we can look at this from a few different perspectives. This is daily new confirmed cases. But where the U.S. is a world leader, unfortunately, up with Brazil and India, if we look at this from a different perspective, for example, case fatality rate, we see Italy and Mexico kind of up here. The U.S. is further down. That suggests that the rest of the world has been able to learn from countries like Italy and their experiences with dealing with serious COVID cases, and translate that into therapies and protocols that have been relatively successful in reducing the fatality rate. So 3 good examples, again, of what we feel are good examples of being able to visualize this data. All right. So in summary, we wanted to leave you with a few points here, and hopefully this has come across. But social determinants is an important and powerful aspect of information on health and healthcare and populations. And we've tried to show some examples of how powerful it is and how it can be integrated into other data sets. It's also easily accessible through the Census Bureau's American Community Survey and other sources. And data on health outcomes, including COVID-19, certainly not limited to it, but that's becoming increasingly available in forms that can be integrated with social determinants data. So we're at the county level with COVID data now, but I suspect it will probably be down to census blocks and census tracts before long, so we can do more comprehensive analysis. So altogether, this provides us with a great opportunity to advance our collective approach to population health, including assessing and managing the impact of COVID-19, but also the many other chronic diseases that are leading both to high costs of healthcare and adverse outcomes throughout the population. Julia, final word?
And there's nothing stopping you. So go get started right now. And thanks for your attention. And we'll take a few questions now.
Very good. And while we're getting to questions, just a quick commercial for Dimensional Insight. We are a analytics and data management software company. We have a specific focus on healthcare, and we'd love it if you could visit us at our booth. We've also been the 7-time winner of the Best in Class award from Class Research.